I'm going to kick off then. So welcome everybody. I'm Gemma Gilbert. I'm a Director of Transformation at Healthy London Partnership, and we're an organisation that provides a sort of convening function, a supporting platform for the homeless health sector to come together, and has been supporting the work on COVID throughout the pandemic. So thank you very much for joining today. We've got a really important webinar for you, and this is about kind of keeping that strong focus on preventing the spread of COVID. So we're going to be talking to you today about how do we support mask wearing and health assessments, how do we support residents through self-isolation, perhaps if they've been tested positive for COVID, or perhaps they're people who've been a contact of somebody who's had COVID. How do we support and reiterate the advice around ongoing vaccination rollout offer to residents and staff? And how can we ground insights that have been shared with us already in peer support and for staff? So we're going to go through a whole range of issues, and we've got some great speakers for you today. And really this webinar has been designed for those people working in some of those accommodation settings, or people working in outreach with our population, just to give them the best opportunity and support to prevent themselves from contracting COVID or from passing it on. So thank you all for being here. So we're going to move straight into the session to give our speakers plenty of time to share their work. And we're going to kick off in the first session with Dr. Binta Sultan, who's a consultant physician in the UCLH Find and Treat team. So Binta, over to you.
Thanks, Gemma. I am just going to pull up my slides. So I'm Binta. I am a consultant with Find and Treat, as Gemma said, and what I'm going to do is just provide an update from Find and Treat point of view in terms of the work we've been doing around COVID testing and vaccination, and just highlight some issues around apologies for sharing that, around infection control and clinical vulnerability. Sorry, just waiting for my slides to load.
We can see those now, Binta.
You can see them? Great.
Yeah.
All right. So in terms of an update, so what we've noticed that's different around in this wave to previous waves is that frontline staff have been brilliant in terms of reporting people with symptoms early on. There's an awareness of symptoms and the importance of self-isolation and supporting clients. We've noticed, we've seen a number of outbreaks among staff. Majority of those outbreaks have been in unvaccinated staff, and we've had some outbreaks as well in hostel settings. When we've done our visits, there's still some sites that are struggling around social distancing and mask wearing, and that's something that I'll talk a little bit about later on. In terms of just comparing this wave to the last wave, so wave 2 hit us very hard, and in particular we had a number of cases in hostel settings where with this higher density of people and increased transmission. So that big red line in January were the number of cases that we saw in hostels. And in terms of where we are in the general scheme of things, so these are positive cases. So as you can see, wave 2 and wave 3 there. So we're just kind of coming down towards the end of the wave 3, just coming down, but we haven't, we're not on a downward slope yet. So we still have to be very aware of COVID transmission and risks. And 2 days ago, we had the highest number of deaths reported, COVID-related deaths reported since January. So still something that needs to be in our minds and present. In terms of the number of cases that we've identified, so since June, we've identified 31 cases and 8 outbreaks just since the beginning of July. And an outbreak is defined as 2 or more cases in a setting. Some of the challenges we have, and I'm going to just speak very briefly about this because I know the other speakers are going to talk about this as well, are the low vaccinations that rates that we've had among people who experience homelessness. So just over a third have had 2 doses, and that's compared to 3/4 of the general population. This is also a London issue as well. So London has fewer people, less proportion of people vaccinated than the rest of the country. And we know that vaccination reduces mortality, and we've all heard these stories of people who've been in hospital about to be intubated who are then asking their doctors for vaccines, and it's just too late then. So those conversations around vaccines need to keep happening, because we haven't vaccinated enough people. The other challenge we have obviously is the Delta variant, and we know it's increasingly transmissible than the previous variant. So if we look at the previous COVID variant, the original variant, one person who had COVID would infect 3 other people, whereas with the Delta variant, that number increases to 7, so significantly increased numbers of transmission. And also, we're all working in settings where there is likely to be higher risk of transmission, because there's a higher density of people and just the type of facilities as well. Just a reminder about COVID spread. So just a reminder that it can be spread through the air, and I think it's something that we forget about sometimes, and it's really why ventilation and social distancing and mask wearing is really important. So when someone's breathing or coughing or sneezing, they breathe out aerosols, which are small particles, and droplets are quite heavy and large and tend to fall very quickly, but it's the aerosols that kind of hang around in rooms. And just got a little schematic that I hope it's going to work. So this is just someone breathing in a room without doors or windows open, and they have COVID. And if you look at how quickly the room fills up with those aerosols, and each of those aerosols contains a virus particle, you can see how quickly we can transmit COVID in these rooms. So that's why ventilation is really important, opening doors and windows. And the other thing, so ventilation is important, and it's something that we found, particularly in hostel settings. It can be difficult, particularly with old buildings, which may not have windows that open very well. But it's really important to just ventilate as much as possible, opening doors and windows. It's easier in the summer, it's harder in the winter, but even opening a door every half hour or something, or a window every half hour, just to increase ventilation within the rooms. In terms of face coverings, in the settings that we're talking about, obviously there is a higher risk of transmission, and we do recommend face coverings to be worn both by staff and clients. And speaking as someone who wore their mask the wrong way around for the first 3 months of the COVID pandemic, it's really important to wear your mask properly. So make sure that the metal band's over your nose, that the loops are behind your ears, and it's pulled down both over your nose and mouth, and that it fits tightly. If you're wearing a surgical mask, you need to be changing the mask every 3 hours, because it's found to be not as effective after 3 hours. And just a reminder about clinical vulnerability. So we know the cohort of people we're working with has a high level of clinical vulnerability. 1 in 3 people are clinically vulnerable, and obviously then at higher risk of complications from COVID. And we're trying to vaccinate as many people as possible. And just having those conversations is really important, particularly for this cohort, but also assessing clinical vulnerability. And we have various tools that are available. So we've got the mini CRISP tool, which is embedded in Chain, so the outreach teams are able to access it. There's also a copy of this on the HLP website, which you can access. And what it does is it allows hostel staff teams and frontline teams to really assess someone's clinical vulnerability and support them into the right sort of accommodation, support them into healthcare, GP registration, and make sure they've had an offer of 2 doses of the vaccine. So this is just a brief run through of this tool. So it just goes through people's the sort of vulnerabilities that increases someone's risk of COVID complications. It's very simple. It takes about 5 minutes to complete, and is a really, really useful tool to try and get people into the right sort of accommodation and prioritise. The other thing, just to briefly talk about that we've had feedback from staff teams, is around the challenges of self-isolation. which can be very distressing both for clients and staff. There's issues around obviously substance misuse and mental health issues, and issues around trust and the relationships between staff and clients. And we only have a short period of isolation, so that period is 10 days. So some of the tools we might have used were not really able to be used within that short frame of time. Obviously, the risk of COVID transmission and the risk of evicting very vulnerable people, which none of us want to do. So just briefly, there is a checklist. Again, this is up on the HLP website, and this was put together with the HDAS team. And it's really about supporting people as much as possible to self-isolate. And the first thing to do is, if someone has symptoms, to make sure that they have access to a test. So either through a local testing centre or through clinical triage with find and treat. And just to be aware of the safety netting and escalating if people are unwell. And thinking about them being able to access food, if they are drinking alcohol heavily, being able to access alcohol, being able to be scripted if they're using heroin, and obviously things support around cigarette smoking and tobacco and nicotine replacement. So there is the issue around police involvement. Obviously, that's not something that any of us want to engage with, and it may exacerbate particular situations. But there are some cases where it has led, the police involvement has led to a change in behaviour, but that's, again, it's a last resort. Similarly, there are some public health regulations, Section 21, that came into force at the end of December, which provide a power for public health officers to ask someone to remain in isolation. Again, this would be a last resort, and often the isolation period is ended by the time that this can really be enacted. So would really recommend that you contact your local public health teams early on if you do have someone who is struggling with self-isolation, and they can support you both formally and informally, and perhaps provide a letter to that person, which might have an effect, and it has had in some cases. I'm going to stop there, just so we have enough time for questions.
Okay, folks. So that was our first one. We did have a few bits in the comments box. We're probably going to take mostly questions at the end, and yes, the slides will be circulated from today. Any more in there? And Alicia's added some further information into the chat box on the mini CRISP survey and links to additional supports and tools, and the HLV vaccination toolkit. So we haven't had any questions in chat as yet, Binta, but if you wouldn't mind sort of hanging on for the end of the session, and then we'll see if any of the participants have kind of thought of new questions as we've gone through the presentations and they come in. So if people want to ask a question in response to that presentation, please do put it in the chat box. We'll keep notice. But we've also had a few questions that were submitted in advance, so we'll kind of come back to those at the end. But thank you, Binta. I think it's really easy to look at the big overall general population graph and see that drop in cases and to sort of relax, isn't it? But I think that's a stark kind of reminder that actually a third are clinically vulnerable in this population. We have a higher level of under vaccination, puts our population at a much higher risk, really. And so we just need to take those extra protective measures. And I particularly like the film and the sort of the filling of the room, which reminds us all what that's like. So not just in relation to residents, but staff, if you're sharing offices as well in these settings, you know, think about that as well, and looking after each other and keeping our community safe from COVID. So with that, I'm going to take us on to the next speaker, which is Huda from Public Health England. She has been supporting the COVID effort throughout the pandemic and is particularly focused at time and attention at the moment on vaccination and how do we close that gap in vaccination. So Huda, over to you.
Thank you for the invite, Gemma. So I'm just going to be talking about the COVID vaccination programme in London. I hope you can see my slides and you can hear me. Yeah.
Yep.
Thank you. So I'm just going to describe the approach to COVID vaccination rollout for the homeless population in London. provide insights into the challenges and facilitators in terms of data capture, data collection, and areas of good practice, and to provide you an update on the current SITREP. So those experiencing homelessness are especially at high risk of exposure due to being in congregate settings or living on the streets, challenges in adhering to social distancing and IPC measures, poor symptom recognition, difficulties with isolation, and challenges with contact tracing. The SAGE report on the 5th of July mentions high levels of transmission can occur in institutional settings, including hospitals, care homes, prisons, and homeless shelters, with infection seeded back into the community. Therefore, appropriate controls will need to be maintained and/or enhanced in these settings. If we look at the government's 5-point plan to manage the virus in the next phase, it mentions reinforcing the country's vaccine wall of defense through booster jabs and driving take-up. So we will continue to offer COVID vaccination to the homeless to ensure that they've had the opportunity to receive 2 doses of the vaccine by mid-September, just as in the general population. We will be offering booster jabs and the flu vaccination to the most vulnerable, subject to final advice from the JCVI. However, in London, we have always prioritised the homeless population in previous years. So if you ask, so where is the evidence coming from in terms of vaccine effectiveness? We know that vaccines are effective against symptomatic disease with the Delta variants, and after a full course, vaccine effectiveness reaches around 88% with the Pfizer vaccine and 67% with the AstraZeneca vaccine. Therefore, findings indicate very high levels of protection against hospitalization with the Delta variant with 1 or 2 doses of either vaccine, but we would obviously prefer 2 doses of the vaccine. The second point of the 5-point plan is to enable the public to make informed decisions through guidance rather than laws. So SAGE recommends appropriate controls will need to be maintained or enhanced in homeless settings. So we have updated the IPC guidance. We have held a webinar on the 19th of July, and we should all be continuing with measures such as vaccination, single rooms, social distancing, good ventilation, masks, and as Binta mentioned, protecting the clinically vulnerable. We have on the 5-point plan also retaining proportionate test, trace, and isolate plans, and we will continue with test, trace, and isolation with support from Find and Treat and the LCRC. Managing risks at the border and supporting a global response. And the 5th point is retaining contingency measures to respond to unexpected events while accepting that further cases, hospitalizations and deaths will occur as the country learns to live with COVID. So we will continue to monitor the data with weekly SITREPs on exposures and outbreaks in collaboration with LCRC, Find and Treat and local authorities, working with partners on identifying suitable isolation sites and increasing bed capacity at Mildmay. So if we look at the vaccination program, we have 3 main definitions. One is the rough sleepers, and the numbers are around 2,287 in London, but also those housed in emergency accommodation and those residing in hostels, with a total of 13,398. We have also included flow into this data, which is around 150 people per week recorded as rough sleeping for the first time. We also know that the movement of this population is quite fluid, and adults may move into different categories of accommodation settings. However, the estimated total population for vaccine purposes is 15,685. So what have we been doing in London? We've been having weekly London COVID vaccination meetings with NHS England colleagues, ICS, GLA, PHE, Healthy London Partnership, Find and Treat and Groundswell. PHE's been working with the GLA and ICS to develop a template for the data collection. And PHE has also supported the weekly SITREP on COVID vaccination uptake. What you will see below is a map. So most ICSs will have access to the shape tool, which is a map of all the homeless settings across London, according to PCN sites that are nearby, pharmacies, as well as GPs, to enable them to facilitate the delivery of the COVID vaccination program. So why is it important to vaccinate the homeless and rough sleepers? Because there's high underlying clinical vulnerability in this group, which mean higher risk of hospitalization and ultimately death, high risk of outbreaks and shared accommodation settings, and the new Delta variant being more easily spread. However, 2 doses of the vaccine is highly effective against the variant. So what can you do to support the vaccination rollout? We wrote to you back in July through Homeless Link. I've sent out a Q&A on the COVID vaccination program, and we asked for your support. So we would like to encourage staff to get vaccinated and advocate for clients to get vaccinated. Staff getting vaccinated at the same time as the clients and Find and Treat have been doing a wonderful job offering staff vaccination as drop-in options. Work with your vaccination borough leads to jointly plan and actively monitor offers and uptake in homeless and rough population. In that communication that was sent out in July, I provided all the information for vaccination leads as well as borough leads in your local areas. Please support data collection and vaccines. Doses 1 and 2 can now be recorded on the chain database. Support the planning of a vaccination outreach or drop in with providers and work in advance to encourage vaccination. And where you can, please use peer advocates from Groundswell. Outreach teams have a key role in identifying, encouraging, and escorting people to pop up or drop in provision. We know that there are challenges and facilitators in vaccine delivery. In terms of the challenges, there is stigma and mistrust, low levels of access to primary care, conflicting priorities, and booking appointments and traveling to them. But we also know that partnership working does work, peer advocacy and training of vaccinators, adequate planning and engagement, opportunistic vaccinations, and outreach. And what's really, really important is that we have a continual offer of vaccinations because we know that motivation can change. Somebody may not be motivated today, but may be motivated tomorrow with adequate information. So some of the challenges we have been having is early planning and communication between stakeholders, and engagement is key, and building of trust and role of peer advocates. We have issues with data collection and data capture. It's not really straightforward. Homelessness is not really recorded in the data capture, and denominator may vary. The delivery model, we know in-reach and outreach works really well, and we do have low reach among rough sleepers at the moment. And there is variation in ICS activity and data collection. So if we look at the most recent SITREP, we have completed 8,928 doses, so well done to everyone. And that's around 63% based on local intelligence figures. And in terms of dose 2, we are around 46%. So we're nearly there in terms of 50%, but we can do much, much better. If we look at the map, a heat map of percentage of completed first dose vaccinations, you will see the areas in amber and yellow. These are the areas where we really do need to increase uptake. So Enfield, Harrow, Waltham Forest, Brent, Kensington and Chelsea, Islington and Bexley in terms of the first dose. If we look at the second dose, I'm sorry to say we have lots of reds because we're not sure whether activity is not happening or there are issues with data capture. So places like Harrow, Haringey, Islington again, Newham, Barnet, Havering, Bexley, Sutton and Richmond. And what I have been doing is reaching out to rough sleeping and housing leads, as well as directors of public health to support the vaccination programme. And I have also been targeting those local authorities with low first and second doses more recently. So the next step, supporting ICSs with data collection and activity, sharing of SITREP with partners, a bottom-up approach, linking homeless settings with local authority and clinical providers, targeting areas where there is low uptake and planning for the second dose and beyond, including winter planning and the flu vaccine. And I just wanted to thank everyone for all their efforts. Thank you.
Thank you, Huda. Huda has been an absolute champion and advocate at a regional level, and is not sort of letting go of that gap. She's been gripping it really hard and putting in all the support that she can. And I guess today is about saying, how do we activate ourselves as a community around her in support of this vaccination effort? So our next set of speakers are going to help us kind of understand better, what's it like from a sort of a peer perspective? What are the providers finding works best in terms of supporting staff with this sort of vaccination effort, and also from one of our social prescribing link workers, what they've been learning about peer vaccination. So we'll come on to them next, and we'll start with Beryl Cross, who's a vaccine caseworker from Groundswell. Thank you, Beryl.
Hello, forgive my techie idiocy, and it's great to be here, thank you. I'm Beryl, I'm vaccine caseworker with Groundswell, and as you probably know, Groundswell's vision is to work towards a more inclusive and equal society with solutions for homelessness coming from people's experience of homelessness themselves. So I work as part of the HHPA team, Homeless Health Peer Advocacy team. And I can tell you about some of the things I'm hearing and doing, which are kind of a little snapshot of on the ground, which many colleagues will be aware of, and which reflect the things that the previous speaker's just been talking about, I think. So what I'm hearing from people experiencing homelessness, being offered vaccination, is go away, I'm fed up with hearing about this. Feeling that they're being over-asked about and over-offered. Is making some people feel suspicious about feeding into conspiracy theories. Why are you talking about this when I've got many other things going on that matter to me? And also some hostel workers are saying to me that constant exaltation is damaging their relationships with their clients. People who are with homelessness are also saying to me that they're scared of the side effects. Particularly rough sleepers are saying they're scared of how they'll deal with side effects when they're rough sleeping. Then there's the vaccine gives you COVID. Some of this is from people who've had first doses and have had side effects, but believe that those side effects meant that they have had COVID, and that if they have a second dose, that will make them feel even worse. And there are the conspiracy theories that everyone will have heard, misinformation. I don't know, the last person was talking to me about how the chickens were all in on it, so there we go. But again, this is people's choice, and as we're talking about kind of being able to make an informed choice is really important. So I'll go on from there to where I'm hearing these things, which is in reach, so that's hostels and day centres, working in partnership with colleagues. That can be providers or nurses, medical professionals, basically knocking on the door and saying, hello, vaccine's coming today, next week, here's some information about it, want to chat, what do you think of it? Outreach, again, working with colleagues such as those at St Mungo's and other providers, again, having a chat generally, how are you? What's going on? Oh, and then, by the way, there's a vaccine being offered today or tomorrow or next week. How do you feel about that? And clients attending health appointments. So there usually is a bit of time when one goes with a client to advocate for hospital appointment or a GP appointment to have a chat about a lot of other things, one of which includes COVID vaccination. So from all those places, I'm hearing similar messages about why is it keep being pushed on us? It's going to cause us to be ill, or it's a plot by the government. That's not the only things I'm hearing. I'm also hearing people say they're considering things, and as the speaker before said, people's motivation changes. So I just want to share with you some of the things that I'm finding helps change that motivation. Working in partnership, obviously, it's so important, and I owe a lot to colleagues that I'm working with, health professionals, sector professionals, find and treat. It makes such a huge difference. Sorry, I've just missed what I'm going on about. There we are. So that's great. Being able to be introduced by a trusted worker, that's excellent too. And I usually start with what Groundswell offers, so they know who I am and what I'm on about. And I also bring in some of my own experience if that seems relevant. Initial chat about how you're feeling, and I've got the luxury of being able to spend the time to listen for as long as it takes to that. So sometimes it does take a long time, but that's great. And to point out that peer advocacy support is offered to people, whatever their views on vaccination. Co-produced written information to leave with people who are having a think about it, not quite sure, is really useful. Groundswell produces information about the vaccination, which has been written together with people experiencing homelessness, and being able to leave that with people and maybe coming back and having a chat another time has been really useful. In-reach and outreach, as was mentioned before, yeah, it's great. In my experience, on the same day as the vaccine's offered works best, just because such a lot of other things come and get in the way. People might say, yeah, I'll come, but then they've forgotten a week later, even if we leave information. Although it's great to be able to leave a flyer too. I'm surprised about how many people came to the last place I was when I left a flyer about the day. So that's really handy too. Sometimes things that happen on the same day cannot be as immediate as one would hope. For example, I was with two people yesterday who really wanted to have a second vaccine dose, who walked with me to the nearest vaccine bus. We found that that particular bus wasn't offering the vaccine that they'd had before, and didn't want to offer an alternative. So just before the two people I worked with grumbled off, I found out from the nurse there that they're actually a vaccine hub at the Science Museum. Both the people came with me in a taxi to the Science Museum. The fact that they peer supported each other and got in the taxi with me to get there and get their second vaccination was great. And they shouted a huge yay when they'd had the vaccine as well, which echoed around the Science Museum. So if people are keen, that peer support from each other as well as us really matters. And, you know, there are people out there who want it, but they want it now, and they won't hang around if it's not there now. One of the things I found that works really well is events that include social time and other health checks, as well as food, fun, and vaccines on the spot. It helps it helps motivate people to want to come because they might come for other health checks, which is great if they take those up. There are vaccine opportunities there. If there's some food, music, and opportunity for socialisation, then the offer and choice of vaccine is one of a number of things that's happening. Just another quick story. I was at a great place where a day centre, there was a Bob Marley tribute band. There was options for vaccines. There was great take up for vaccines on that day. I was chatting to somebody who was hesitant before the tribute band came on. He dared me to dance to the tribute band, which I did, and made a complete idiot of myself. Anyway, this apparently pleased him so much, and I don't know whether it was connected, that he stood up afterwards and said, oh, well, you can seize the day, let's go and get a vaccine. So off we went together. I think there's just something about being in it together. I mean, I'm not suggesting that one of the things that works is making a fool of oneself, but I just wanted to share that with you. And what's next? Previous speakers have spoken about this, but obviously building on partnership expertise, knowledge, and sharing learning. It's so great to be here and to hear from other people. It's really important. Maybe continuing to support health promotion checks and social time offered together with vaccine opportunities. That does take a lot of planning, and it does take a lot of resource. But in my anecdotal experience, it works really well in terms of vaccine take up for people who are rough sleeping, as well as those who are using hostel accommodation. testing out evening vaccine opportunities. I don't know if and where that's happening, but certainly maybe that's going to catch people or give people off the opportunity when they're not around in the day, and one-to-one appointments, which we can help with, of course. I mean, it is, as we all know, the choice of individuals, and the hesitancy, I think, is reflected in the more general population. But it's so focused and important with the people we work with and for. And I feel privileged to be able to be part of that work. Thank you. And if you want to contact me or the amazing coordination administrator to talk about how we can support your work around vaccine take-up, then be delighted to hear from you. Thank you.
Thank you very much. Just to remind everybody, we are sharing these slides after the webinar, and we're also going to continue on as a recording. So if people reach a point where they had to drop off, we're going to be sharing the recording as we go. So we're not sort of restricting too hard the speaker's time in order that they can kind of really share all of the key information with a much wider audience. There was a really interesting question in the chat about what sort of specific advice might we have for drug users who are worried about interactions. I thought it was a really helpful question from Denise. We'll do some follow up on that. I've shared one initial piece that I found online, but we'll make sure that there's some sort of clear advice around that and support work with Groundswell around how might we put that out. So let's move straight on then to Stephanie Ratcliffe, who is going to give us a provider perspective from St Mungo's. Hi, Stephanie. Over to you.
Hi, everybody. One second. Slides. Okay, I can't see you, but hopefully you can see the slides.
Yeah, your slides are up, Stephanie. What we can't see them in full slideshow view. I don't know if you've put them in slideshow view yet.
I have.
Okay. I mean, don't worry, because we can see it on screen, obviously.
Okay. I'm just going to carry on because if that's okay, just yeah, because of time. If you can see it. So I'm Steph, I'm from St Mungo's, and I am going to talk about the work that we are doing to maximise vaccine uptake amongst our client group. So that might include people who are currently sleeping rough, or people who are in emergency or supported accommodation. So the first thing I'm going to say is what works is remembering what we already know, and remembering what we were doing around promoting healthcare amongst our clients, promoting engagement with health services before COVID, and using that as a framework in which we can think about vaccination uptake. We know that some of our clients will be at the start of their recovery journey, and at the point at which we're working with them, they're not yet ready to talk to us about their health, to access treatment, or to make changes to their lifestyle. Where clients are pre-contemplative, hope I pronounced that, or just not at the point to start thinking about their health, our role is to build trust and rapport and help them explore that. And it's helpful to remind our staff of that, because otherwise we can get to a frustrating situation, which it's really interesting that what Beryl said previously around clients are sick of being asked, and we are very much trying to manage that. We know it's so important that our clients get vaccinated, that we really want to do everything we can to make that happen, but we have to do that in a way that takes into account where they are in their journey and doesn't cause them to further disengage. We know that there are many reasons for vaccine hesitancy, and these are specific and personal to the individual. But I think we also know that communities who have poorer health outcomes or poorer experiences of healthcare may feel they're less able to trust healthcare services, and that might lead to concerns about vaccination, and that's certainly the case. It can be the case for some individuals who are homeless or have an experience of homelessness. And I think, you know, it's interesting when we talk about vaccine conspiracy theories, and, you know, to what extent does an individual who is saying, I don't want to get the vaccine because of Bill Gates or you know whatever particular conspiracy theory they cite. You know, I think we need to ask ourselves: is the person saying no because of a conspiracy theory, or are they saying no, Bill Gates and a chip, because it's easier to say that than to explain actually the last time they went to a doctor's they had a really bad experience and they can't face going through that again, so they're just going to cite the conspiracy theory. I think it's really important for staff to be clear on our role in this, and you know, because of the importance of this and because, you know, vaccination saves lives, your staff, they feel a pressure to get this right, and it can cause anxiety. So it's really, really important that staff know exactly what their role is, and you know, that is to hear clients' concerns with empathy and without judgment, and to facilitate conversations about clients' concerns. And I guess, you know, to help them think through the pros and cons, and to critically assess the information in front of them, and ultimately to empower our clients to have the autonomy and self-confidence to make the choice that is right for them. So what does this look like in practice? Well, I'm just going to go through a motivational interviewing toolkit that we've produced to help our staff with this. I don't know about you, but sometimes motivational interviewing can feel very theoretical, actually we just wanted to bring it down to the basics, really simplify it, and take the core components of motivational interviewing and think about that in the context of vaccination. So hopefully you can see the next slide and shout if you can't. So the first thing is to ask open-ended questions. So our role is to get the client talking and hear their concerns. Most importantly, you don't need to have all the answers. It's about that conversation. So saying things like, it sounds like you're sure but you don't want the vaccine, and that's completely your decision. Do you mind if I ask why? It's just repeating what the client has said back to them, and that thing about, oh, do you mind if I ask you why about that? I'm interested. Again, point 2, reflecting back what the client has said with empathy. To show that you've heard what they've said and that you take it seriously, and to resist the temptation to get into not an argument, but a sort of, oh, I'm not sure that's correct, but find a way to take part of what they're saying and or a theme of what they're saying, and show that that's I take that really seriously. So you've mentioned safety concerns, and it's normal to be concerned about this. You mentioned that you're worried about whether people from your community were included in the trials. So, I understand why this is important. Would it be helpful if you had some more information about this? You said that you read the vaccine is fake news. I'm not surprised that you're worried about that. And I think, finding a way to show that you've heard even the kind of the more outlandish things around conspiracy theories and fake news, and be like, actually, let's talk about that. Okay, so the next thing is asking the client to think through the pros and cons, and finding a way to highlight the client's strengths to build their self-esteem. So it sounds like you're doing a lot of reading about the vaccine. Can you get a variety of views so you can weigh up the different information? Well, you've clearly thought a lot about vaccine safety, and I know a lot of people are thinking about this at the moment. Have you been able to read anything? Or asking the client to weigh up the risks of getting it with the risks of not getting it, and thinking about their particular situation, the things that they want to do as society opens up, and does that change the risk profile for that individual? I think it was interesting what Ben said at the beginning, that certainly during the first wave there were fewer cases than perhaps we might have expected amongst the rough sleeping population, and what that potentially means, or what we are seeing in some areas, is individuals thinking, oh, this doesn't affect me, like I'm all right. I got through the first wave where everyone was really worried, so it'll be fine. I've got a high level of resilience, and we just need to support the individual to think through their own risk management strategies, which we know that clients are very good at. They do a good job at keeping themselves safe in some really risky situations. So it's about using those skills that a lot of our clients already have.
So Steph, it sounds more like a kind of coaching, empathizing, listening kind of role rather than a telling and an information role, doesn't it?
Yeah, definitely.
I've just sort of come in only just to let people know that for people who had to leave at the kind of end time of the webinar, that's fine. We're carrying on and we're recording just so that it can be shared, and hopefully you've got a sense of some of that guidance from Steph around sort of that role playing, really, about let's practice what we're going to say a little bit. And I want you to hear from Ikran as well, but around her experiences as a social prescribing link worker. So Steph, back to you for sort of final words on this one.
Yeah, sure. So the fourth one and the last point I was going to make is about summarising the conversation. So it sounds like you don't want the vaccine, and you can't imagine the situation in which you might change your mind. And it's important just to say that and show that you've heard it. Or you might reflect some next steps back if there are any. And then some final three things then, just to remember, it is normal to have questions about healthcare, especially when it's new. So like we as key workers, as support workers, we should be encouraging this. Again, avoiding the temptation to argue with the client or to, say what they're saying is wrong. We need to hear it and encourage them to think critically about it. And our personal experiences play a big part in our decision-making process. So it's important to hear and to validate each other's experiences. Thank you very much.
Thank you, Steph. That's great. It's a really good source of advice and information for people on the front line. I'm going to invite Ikran onto the screen. And I'm really excited to have Ikran on the screen because social prescribing is still a fairly new thing in London. So people who don't know, we now have hundreds of social prescribing link workers across London who are becoming a connecting piece between the community and the health system, and are providing a really strong advocacy role during COVID. And, you know, it's been amazing to see the work that they've been doing as a sort of a new workforce, supporting communities and their access to healthcare. So welcome, Ikran. And I know you haven't got any slides, but you were going to tell us about social prescribers and how they've been supporting vaccine rollout, and also any advice you have for the homeless access in terms of vaccines and the way that people are helping to support them in accessing those. So over to you.
Hi everyone, thank you Gemma for having me. I'm Ikran. I'm a social prescriber link worker currently for West Hill Health Primary Care. However, I was a social prescriber for Hounslow Borough. So there I'll be discussing my experience at the Hounslow, where I previously worked there, in relation to homelessness and rough sleepers, and the initiative I was involved in the need of increasing the uptake amongst uptake of COVID vaccination amongst the homeless group. So what I realized that it was really important for the homeless community to be aware of information regarding the COVID vaccination and being aware of where it's being held, how they could get those details. It was important for me to also, for them to also know that vaccination was for everyone, and each person has the right to right to it. However, knowing the homeless and rough sleepers is known for them being quite very vulnerable, and a lot of them lack access to the basic rights towards healthcare. And a lot of them, through my patients, talking to my patients, I found out that a lot of them felt that they didn't even believe that they were entitled to vaccines or healthcare. And also a lot of them are not registered with a GP or have an NHS number or even have an address. On top of that, they felt quite nervous and reluctant to approach staff because they felt that they might be judged for the way they dressed or the way they looked. So because of that, they avoided going into clinical settings. For these reasons, it was really important for me that the homeless community did not feel like they were being left out of the COVID vaccination. And it was important for me to emphasize that the initiative for the COVID vaccine was for everyone. And what I did with that was I worked closely with patients I was referred to who were either homeless or rough sleeping. And with that, I worked with shelter organisation in offering them the COVID vaccination. With that, I even sat down, went with them, accompanied them to the vaccination clinic hubs, even trained myself as a vaccinator. So if they felt more comfortable, I even vaccinated them. Before they even had their vaccination, I offered for them to any concerns or questions they had to be answered, such as was it safe for them to still have the COVID vaccination even if they were using alcohol or drugs. And I got that support with the help of the nurses and clinical leads at the vaccination hub. I also liaise with many different organizations, such as My Independence, which is a housing organization, Street Link, Nishkam SWAT, which is a homeless charity. And on the 1st of June, Nishkam Homeless Charity partnered with the NHS to give the homeless and rough sleepers and non-documented migrants the COVID vaccination. And this was led by Dr. Kuraj Run, and I worked closely with him previously with another project where we focused on increasing the COVID vaccination amongst the Asian community and undocumented migrants. So when I heard that he was leading this initiative, I got in contact, asked the details, asked the place of the event, how people could come. And with that, I laid it back to my patients, telling them about the event, where they could go. I also shared it with other organizations, shelter accommodations, even advised their staff to print out the leaflet and encourage those who come into the shelter to come get the vaccine. If they have any question, that we were going to be there, and that even if they weren't ready to have it on that day, they could just come and ask questions. The questions could be answered. So it was just a process of them just feeling like they could go and approach someone and get the question they need and not being forced to have it there and then.
So there's a common theme here, is it, with the last presentation of don't, be clear it's somebody's choice, sort of allow them time to express their view on the vaccine, listen, and then coach them and make them available clear on the options. Yeah, it sounds though like Ikram, you have been an amazing advocate within the sort of social prescribing field, and have been so proactive in personally going out, finding more information, and changing your practice up to help kind of with that reach and in reach. So that's amazing. Is there any sort of final words that you'd like to say for the group, or final reflections?
What I would say is just definitely just having that open conversation with the community, is listening to them, hearing what they want. So the COVID is going to be there, and it's something we're going to have to live with, but it's just having that conversation and allowing them an opportunity to speak about their care. So it's mostly for them and how they want it to be done. Definitely.
Amazing. Thank you so much. And it's lovely to meet you. So that kind of brings us to the end of the presentations. There is time often for people who want to do final questions, but we're coming up to the 30-minute mark. We haven't had any additional questions in the chat, but we had some submitted in advance. So given this webinar has gone on for slightly longer, what I'm going to suggest we do is provide a written response to those questions, but send them out to everybody, so you can kind of see what people were interested in, and we can send those out to you. But we do encourage ongoing dialogue. As a community of homeless health people at the front line, you can always submit more questions that have come up during this webinar that you feel would be helpful to have an answer to. A huge amount of resources have been going into the chat box, so as well as the slides, we'll make sure that those are circulated too. So on that note, I would just like to say a massive thank you to our speakers. I would like to say a massive thank you to all of you. This vaccination, closing this gap, is so important. I've had my vaccine. I've also had COVID. I could tell you the after effects of the vaccine were a lot worse than COVID. But sort of supporting and encouraging those around you is really important, and it's so important as key workers. What's clear from the research we look at is that people who are staying in these communal settings, they absolutely trust what their key worker says to them. So be absolutely armed with the key information that you might need, and think about that coaching advice that you've had from Steph in terms of the types of words you might use. And I hope that supports you all in your roles in sort of protecting and supporting that sort of health and safety and preventing transmission on site. So with no further ado, I'll just sort of say another thank you to the speakers and wave at you. Thank you very much. That was great. And we're going to get this recording out to everyone as soon as possible. So have a nice day, everybody. Take care.